So to summarize, we have this 74-year-old gentleman with some mild renal insufficiency and has symptomatic myeloma. And so let's get some input from Pei from a pathology perspective. What do you think is the appropriate diagnostic workup for this type of a patient?
So for patients with a diagnosis of myeloma, we usually like to start with review of peripheral blood and to assess whether there are increased circulating plasma cells, which is a features of adverse prognosis. And we also perform bone marrow aspiration and biopsy, and to assess the extent of disease involvement. Sometimes the aspirate can maybe end estimating the tumor load, and the biopsy we should perform CD138 to see the extent of tumor infiltration. We also assess...
Maybe I can ask a question, because I think we often ask house staff, if you have clear evidence of monoclonality, why do you need a marrow?
The marrow assessment is very important in the extent that we also assess the vessels. We evaluate for amyloid deposition. We also assess the bone tuberculate to see lytic lesions. It's overall evaluation of the bone pathology as well as the neoplastic cells. Additionally, the morphology of the plasma cells, particularly plasmablastic variant, is known to be an adverse prognostic factor. So these are also reported in our usually pathology report.
Any additional considerations for an older patient?
For the older patients, concurrent cytopenias or any other factors would raise concurrent MDSs, or for instance, we routinely perform iron scan just to make sure that some of the patients who come in, they have anemia, they might have concurrent other disease, maybe related or unrelated to myelomas. For instance, this patient has anemia, but this patient could have anemia due to some other causes as well. So these are very important, and it comes down also to assessment of the cytogenetics and FISH. In this particular patient, he has a T14/16 translocation, which is, as you mentioned, an adverse prognostic factor. We also perform conventional cytogenetics and a panel of FISH to make sure there are no other concurrent adverse prognostic factors, such as, we will talk about 414 and deletion 17, which these can combine the adverse prognostic factors could add further poor prognosis. So am I talking too much now? Or I think
no, you're great. And maybe we can just close the pathology component with the relative laboratory work.
Yeah, so we also perform flow cytometry. This gives us a baseline as to what the phenotype is. The myeloma cells usually have a aberrant expression of 56 and CD117, and sometimes they lost like CD45. These will be very important for future follow-up studies for monitoring of minimal residual disease.
Perhaps you could, since you brought up the flow, mention light chain restriction, the difference between myeloma and lymphoma in terms of cytoplasmic versus surface.
Right, so the plasma cell usually have the cytoplasmic light chain restriction, whereas the B cells, they usually have the surface light chain restriction. The plasma cells, as we know, are terminally differentiated B cells. They lose the surface light chain expression. Additionally, the light chain assessment sometimes may be difficult because some myelomas can be non-secretory, so it will be very important to assess the overall pattern. The aberrant surface expression could be an indication of aberrant malignancy rather than the cytoplasmic restriction patterns itself.
Great. Thank you so much for that important pathology perspective.